Welcome back to another week of Small Parts Lecture. So this week we're going to discuss the male pelvis, and we're going to discuss the scrotum, the penis, and the prostate. So we're going to focus a lot on the scrotum, and that is because that is a very common test that is ordered. The penis and the prostate ultrasound orders are mostly going to come in through your urology clinic or the random ER, or maybe you'll end up working in a small hospital that will have a doctor that just wants you to try it. So we're going to give you a basis of those other two organ parts, but really focus on the scrotum. This is going to be heavily tested on your abdomen boards. And again, it's something that you're going to do daily, weekly, if not daily. So let's go ahead and get started with the scrotum. So let's first get acquainted with what the testicle anatomy is. During embryology, the only thing that you need to know, and it's important for pathologies later, is that the testicles actually start up in the abdomen, and then they descend down into the testicles around week 28. And why is that important? Well, when we know when anything has to move in the body from the abdomen to somewhere else, it has a potential to get lost, right? Just like kidneys, those move pelvis and up, they get stuck down in the pelvis. Testicles, same thing. They can get stuck somewhere up in the abdomen, never make it down to the scrotum. So that's why that's important. So out of this, just remember that the testicles do descend and that they should be in the scrotum by 28 weeks. Location-wise, the testicles are typically within the scrotum. And when you look at the scrotum, you can tell that there are two sides to it. And those sides are divided by something that actually has a name. So the external division is called the median raphe, and it's just kind of this fibrous tissue. You can tell there's kind of this like line on the scrotum sac. That's the median raphe, and it actually extends up and through the penis. You can see the line all the way through. Internally, though, it's called the tunica dartos, and it's something that we can see by ultrasound, not something that we particularly evaluate, but it is the structure that splits the scrotum into the two halves. Now we're going to go over the anatomy of the testicles. We're going to talk about some coverings first here, and then we'll talk about intratesticular structures, and then we'll talk about the extratesticular structures. As far as knowing your anatomy goes, I think spending some time with these diagrams and really understanding what we're talking about, what we're looking at, is going to be beneficial. There's going to be labeling. You're going to get some practice on it in your workbook. Just really take the time to make sure that you're comfortable with these structures. So when we talk about them on ultrasound, that you'll be able to visualize these diagrams and then kind of know what we're talking about. So there are a couple layers that surround the testicles. And the first one is called the tunica vaginalis. And the tunica vaginalis is kind of like the peritoneum in that there's two layers to it, the parietal and the visceral side. And in all actuality, the tunica vaginalis actually is kind of an extension from the peritoneum. So this is up into the body here. This is our inguinal canal, and the tunica vaginalis kind of comes down and around. And so we come down here and we have those two layers. The layer that is closest to the scrotum wall is the parietal side, and then the layer that's closest to the testicle is the visceral side. So just like with the peritoneum, the parietal is towards the wall, visceral is the one that actually sits on the organs. And what's important about the tunica vaginalis is that it communicates with the peritoneum. So if there's fluid can easily leak down and in and around and sit in between these two layers. And we'll talk about it in a little bit. There's pathology called a hydrocele, and that can fill in this area with fluid. The other important part about the tunica vaginalis is that it does not entirely cover the testicle. There is actually kind of the superior part and this backside part that is not covered, and so we consider that the bare area. And that's again important too, because that bare area kind of anchors the testicle into the scrotum. If that tunica vaginalis kind of wraps up and around the testicle all the way, then we call that the bell clapper syndrome, and that leads to more acute cases of torsion. And we'll talk about that again later as well. The tunica albuginea then is the next cover in. So we had parietal layer of the tunica vaginalis, then we have the visceral layer of the tunica vaginalis, and then we have the tunica albuginea. So the tunica albuginea is a very dense fibrous tissue that covers the testicle. We can see it on ultrasound. It looks very bright. But what's important about the tunica albuginea is that it's going to come in through the mediastinum of the testes. So when we look on ultrasound, we're going to see this bright white dense fibrous line on ultrasound, and that's the mediastinum testes. And then what happens from the mediastinum testes is that it then extends into the testicle, creating septations. And those septations separate out the lobules of the testicle. We can't see those septations on ultrasound. We can't see the extension of the tunica albuginea into those septations. The only thing we can see is that bright white line around the testicle, and then we can see the brightness of the mediastinum testes as well. Speaking of small parts of the testicle, then, just like the breast, the testicle has lobules, and inside the lobules are where the functional parts of the testicle reside. And so there are about 250 to 400 lobules within the testicle, and each of those houses part of the seminiferous tubules. And these seminiferous tubules then are these orange things, and they sit within the lobules. You can kind of see the image has them kind of separated out. So the seminiferous tubules are these long tubes that are all kind of folded up on one another. And this is where spermatogenesis occurs. So this is where the sperm are made. The seminiferous tubules then are going to exit the lobules, and they're all going to converge together in this area called the ret testes. And the ret testes sits within the mediastinum testes. So the ret testes then is going to take those sperm that were made in the seminiferous tubules, and those are going to exit the testicle and head out through the efferent ducts. Those are those purple ones here. The efferent tubules then are what connect the epididymis to the testicle. And the efferent ducts head right into the epididymis head. So remember that the efferent tubules connect the testicle to the epididymis head. Speaking of the epididymis, then, it does have three distinct portions. We consider the head of the epididymis to be the part that connects to the efferent tubules. It's the beginning of the ductus epididymis. So all those efferent tubules will come into the epididymal head, and then they're all going to converge into one tube called the ductus epididymis. And the sperm hang out in the epididymis to mature, and once they're mature, then they exit. So they're going to start up in the head, and the head sits more on the superior side of the testicle. And then laterally to the testicle, we have the body of the epididymis. As we keep moving inferior on the testicle, then we run into the tail. So the tail is the largest portion of the epididymis. It's where we see a lot of pathology start. And out of the tail of the epididymis, we have the Vas Deferens, or the deferens duct. That's that blue one here. So as the sperm then exit out of the testicle and into the vas deferens is going to travel up through the spermatic cord. And the spermatic cord is actually home to a few different structures. So know that it's home to lymphatics and autonomic nerves, but most importantly, it's home to the vas deferens. That's the tube that's going to carry the sperm. It's home to the cremaster muscle fibers, which are muscles that head out into the scrotum, the testicular arteries, and the venous pampiniform plexus. So the vas deferens is a muscular tube. It transfers the sperm from the epididymis up to the seminal vesicles. So again, sperm is made in the seminiferous tubules. They go through the ret testes, then the efferent tubules into the epididymis. They follow the epididymis around and out into the vas deferens, and the vas deferens are going to bring it up into the body and then out through the urethra. The cremaster muscle then is this layer here. This is just muscle that sits around the testicle and then up into the inguinal canal in the spermatic cord. Its main job is to raise and lower the testicles. The testicles are very sensitive to temperature, and so the cremaster muscle can raise them closer to the body if they need to be warmer and drop them lower if they need to be cooler. So the vas deferens comes down and around, and it has this widening right at the end of it, and that's called the ampulla of deferens. The ampulla of deferens then is right before the vas deferens joins with the seminal vesicle. The seminal vesicles then are small glands that sit on the posterior side of the bladder, and they are responsible for adding fluid to sperm to make semen. So remember, as of right now, as the sperm are traveling through the tube, they are just sperm. They are not semen at this point. So sperm, 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 hit the ampulla of deferens, join up with the seminal vesicles, ta-da, semen. Okay. So, and we'll talk about this a little bit more in physiology. So the ampulla of deferens dumps into the seminal vesicles. Seminal vesicles have their own duct. Once the vas deferens and the seminal vesicle duct join together, they create the ejaculatory duct. And the ejaculatory duct is going to travel through the prostate. The prostate then actually adds a little bit more fluid to the semen mixture. And the ejaculatory duct is going to connect then with the prostatic urethra. And the prostatic urethra is that first little chunk of urethra that comes out and travels through the prostate. And the ejaculatory duct and the prostatic urethra are going to meet up at the verumontanum. Verumontanum. That's kind of a fun word to say. So they meet up right at the spot here, and then the prostate, which is kind of muscular during ejaculation, will push the semen out of the rest of the urethra and out of the penis, out of the body. All right. So just to kind of recap, because I jumped ahead on my slides here, the verumontanum is where the urethra and the ejaculatory duct join one another. And then the urethra is responsible for bringing both urine and semen out of the body. Now there are some little hunky things that can hang off of the testicle, and they can hang off in different spots. And you'll see these by ultrasound. And when you do see them, you'll want to document them, document where they are, make sure that they have blood flow in them. But the most common one is called an appendix testes. And basically what it is just this like little remnant of testicle tissue that hangs off the side. I feel like I always kind of see them up on the superior side, but they can really be anywhere. The next most common one is the appendix epididymis. And same idea, it's just this like hunk of epididymal tissue that hangs off the side. And so again, you'll just want to document them if you see them. Vas Deferens and an organ of Geraldes are other locations that the appendages can pop up, but they are not nearly as common. So then the last part, just to review, is the arterial supply. And the arterial supply, don't get super hung up on this, on how everything is fed from the aorta. But basically what happens, the aorta has its own branch of to the testicular artery, again bilateral, and the testicular artery is going to come down. So that's kind of our main artery coming into the scrotum. It's going to travel through the spermatic cord. And when the testicular artery gets down to the testicle, it's going to branch into the capsular artery. And so the capsular artery is this kind of outside part. And this is one that you can see really, really well when you put Doppler on. You can see this one usually pretty well. From the capsular artery, then, you're going to see these kind of streaks of blood vessels coming into the testicle. They're first going to be centripetal arteries, and then you're going to see those centripetal arteries almost curve around like little candy canes into the recurrent rami. So you can actually see these little curvatures of these vessels as they come in. Now, when we do Doppler on the testicle, I like to look in a couple different spots. I like to make sure that the capsular artery is nice and patent, that we can see that really well. I also really like to look at the mediastinal artery. But when I Doppler, I want to Doppler somewhere out in the tissue on one of these recurrent rami. And that's because I want to make sure that I'm getting evidence of blood flow to the very central core of the testicle. Now, say somebody has some really hard vessels to see, and for some reason I just can't really see in the middle, I absolutely will take something on the edge. But for the most part, I do try to get into kind of the central portion of the testicle. Now, are some other arteries that kind of hang out in the area. The cremaster artery and the deferential arteries both come off of the iliac artery. So remember that the testicular artery comes off the aorta. The other extratesticular structures are fed by iliac artery branches. So we have the deferential or the Vas Deferens artery and then the Cremaster artery. And these are going to go to feed things that are outside of the testicle. So the Cremaster artery is going to be more on the periphery, feeding like the wall and the muscle, that kind of stuff. And then the Vas Deferens artery is going to feed the Epididymis and the Vas Deferens. All right. So again, don't get too caught up on this. I think I would know that the testicular artery is an aortic branch. I would then know what the capsular artery is and the recurrent rami are. I think those are probably going to be maybe 3 terms that are really definitely going to stick out board-wise. Venous drainage then is made from a network of veins that come out of the testicle. So a bunch of tiny little veins are going to come out, and they're going to converge together into the pampiniform plexus. And so the pampiniform plexus, you can kind of see here, is like almost a net-looking network of veins that are exiting the testicle through the spermatic cord. Now here's the big thing that you need to know about the pampiniform plexus. Number 1, the right testicle drains into the IVC. So right pampiniform plexus heads right to the IVC. Now the left testicle, though, that's going to drain first into the left renal vein, and then the left renal vein will take it back to the IVC. This is important later for pathology, but remember, right testicle directly to the IVC, left testicle into the left renal vein will take it back to the IVC. So let's get into some of the variants that we see with ultrasound and the testicles. So one of them is cryptorchidism, and crypt means hidden. Orchid is Latin for the testicle, and so it's hidden testicle. And remember, they start up in the abdomen and they descend down into the testicles. They have to move from the abdomen down into the testicles. Well, they can get stuck anywhere along the path that they normally take. And so what we typically see them getting stuck is in the top of the scrotum and into the inguinal canal. They usually get stuck somewhere in there, and we can see them up there. And if we do, we should document where they are and measure them and do all that stuff. Every once in a while, they don't even make it down there, and they kind of hang out in the abdomen almost right before it gets into that inguinal canal. Now, because this testicle is hanging out in the body and doesn't have the option to be lowered away for that temperature regulation, we find that cryptorchidism leads to a higher incidence of malignancy, torsion, and infertility. So most patients, I would say, now that we have regular pediatric care, most people will know if they have an undescended testicle, if not at birth, very shortly after. It'll be seen early in their well child visits. So it's not uncommon to get exams for these for very young children or pediatric population. If these patients are found to have an undescended testicle, usually what it needs is surgery. They'll go up and get the testicle, they'll bring it down into the scrotum sac, and then they'll sew it to the testicle wall. And so then won't pop back up, because sometimes they can kind of come in and then come back out. And so that's something that we would document as well. Another example of a testicle in the place that it shouldn't be is called testicular ectopia. And you might be thinking to yourself, well, isn't that the same as cryptorchidism? And it's not. And that's because cryptorchidism, we find them somewhere along the path that they would descend from the abdomen into the testicle. We find them along the path. Testicular ectopia is when the testicle has gone somewhere so completely abnormal, it has no chance of getting into the testicle. There's no moving it into the testicle naturally. And so some of those places that we can get is above the penis. We can get it over into the other testicle. We can get them behind the testicles in the perineum, or we can get them up and kind of onto the thigh. These ones would need to be probably just removed. I don't know that they'd be able to take these out and then place them back in the scrotum sac. So same idea though, if the testicle is not in a place that it can be temperature regulated, again, we're going to see infertility, malignancies, and torsion possibilities. Anorchia then is the absence of the testicle completely. Again, if a patient does not has an empty scrotal sac, either one side or both sides, they're going to have an ultrasound ordered, and we're going to go look for them. And more often than not, again, we find them somewhere in the inguinal canal. We're good to go. They can do surgery and fix it. Sometimes we can't find them at all. And so then the patient's going to need other imaging, maybe an MRI, maybe a CT, and they're going to look for the testicle somewhere in the abdomen. If they don't see it up there, then they can officially be diagnosed with anorchia. Polyorchidism then is having more than the 2 testicles that you're supposed to have. So it's a really pretty rare disease. More often than not, it's on the left side, and that 3rd testicle is usually a little bit smaller and not as functional as the other 2. All right, testicle physiology. So the testicles function as both endocrine and exocrine organ, right? So remember, endocrine is anything that is released into the bloodstream. So those are hormones put out into the bloodstream. Remember, the pancreas is an exocrine and endocrine. The pituitary gland is an endocrine. Anything that releases a hormone out into the bloodstream. But it's exocrine because it has a duct that it releases things through as well. So remember, the pancreas has the pancreatic duct that it releases juices through. That's why it is considered exocrine and endocrine. It has 2 functions. So the endocrine part of the function of the testicle comes from the interstitial tissue of the testicle. And the interstitial tissue is the tissue that sits around the seminiferous tubules. And in the interstitial tissue are the Leydig cells. So this picture here, we have this blue. This is supposed to represent the lining of a seminiferous tubule. So we're getting a cross section of the tubule. On the outside of it then is that interstitial tissue, and that's where the Leydig cells are found. And the Leydig cells are responsible for creating testosterone. I wish I had a clean example of how to remember this, but I think you guys could probably figure out how Leydig cells could be related to testosterone that you can share amongst yourselves. The seminiferous tubule then is where the exocrine function occurs. Again, remember, this blue tube is kind of a cross section of the seminiferous tubule, and it contains a lot of different cells, but the main ones that you need to know are the Sertoli cells, these kind of big gray blobs. And the Sertoli cells are where the sperm are produced. So the sperm are produced in these Sertoli cells, they're emptied into the seminiferous tubule, and then they head out of there. Testosterone is considered an androgen, and androgens are sex hormones. And for men, testosterone is what initiates and maintains their body changes that are associated with puberty. So lowering of the voice, increase in hair, both on the face and body, changes in musculature. So anything that goes along with male puberty is usually due to testosterone. So how does spermatogenesis occur? Well, first off, the pituitary gland is going to release luteinizing hormone and follicle stimulating hormone. So those probably sound familiar from GYN class, right? And the luteinizing hormone is going to tell the Leydig cells, remember the Leydig cells are responsible for testosterone, it's going to tell them to make some testosterone. So luteinizing hormone, L, goes with the Leydig cells, L's, so we got 2 L's there, to make that testosterone. The follicle stimulating hormone then is going to tell the Sertoli cells to make sperm. So we've got follicle stimulating S hormone tells the Sertoli cells, the S Sertoli cells, to make sperm, S sperm. So we got S's there. So L's for testosterone, S's for sperm. And when the body has both follicle stimulating hormone and testosterone, that is when spermatogenesis can occur. So what do you need to know out of this? Know that you must have both follicle stimulating hormone and testosterone to create sperm. As promised then, we would talk about how the sperm get out of the body after they are created in the seminiferous tubules. So we're going to start in this corner here. So the sperm, long form spermatozoa, are created in the seminiferous tubules. They are then going to exit the tubules through the ret testes. Remember, the ret testes come together in the mediastinum testes. The ret testes then are going to exit the testicle through the efferent ductules, and those are going to go into the head of the epididymis. From there, they're going to hang out in the epididymis to mature. As they are maturing, they're going to slowly move through the ductus epididymis. Remember, that's the tube within the epididymis. The ductus epididymis is going to turn into the vas deferens, and that's going to exit out the tail of the epididymis. The vas deferens then is going to travel through the spermatic cord, up and around and past the bladder, where it's going to connect with the seminal vesicles. Remember that the ampulla of the deferens and the seminal vesicles sit right next to each other. Once they combine, they create the ejaculatory duct. Now that we have some fluid added, we're starting to make semen. And the semen is going to go through the ejaculatory duct, and it's going to get a little bit more fluid added by the prostate, and now it is true semen. Nope, we're down on this one. Now it's true semen. The semen is going to continue through the ejaculatory duct and go into the urethra, and it's going to meet at the verumontanum. From the verumontanum then, it's going to continue exiting out of the body through the urethra. So knowing the path of the sperm is good. It also helps you just to kind of revisit all of those organs that we talked about as well, all those kind of stops along the way. So that'll just be a good way to recognize the anatomy and the path of the sperm. So here again we have our pathway. We start in the testicle, we exit the testicle through the ret testes and the afferent tubules into the epididymis. They hang out in the epididymis, travel down and around through the ductus epididymis and through the vas deferens. Vas deferens brings them up and out and around, and this at this point this is during arousal, during ejaculation. So the muscle squeezes the sperm up. We're at the ampulla of the deferens here, and we join up with the seminal vesicles to create the ejaculatory duct. We get a little bit of fluid from the seminal vesicles, we get a little bit of fluid from the prostate, and then we meet up with the urethra at the verumontanum. From there, then the ejaculation occurs out of the urethra. Knowing that sperm are sperm and only sperm until the fluids are added by the seminal vesicles and the prostate, at that point it does become semen. The seminal vesicles mostly add a fructose-based substance, and that just gives energy for the sperm to make their big swim. And then the prostate adds some citric acid and calcium and just kind of helps the sperm from sticking to one another. All right, so let's take a look at what some of these structures look like under ultrasound. So first we have our testicle. It is nice and homogeneous. It should be kind of a mid to low level gray. And here's an example of the mediastinum coming through it. Another example of testicle and transverse. Again, we can see that mediastinum here. This is all scrotal wall around it. Here's that tunica dartos that we can see splitting between the two sides of the scrotum. Again, we've got scrotum wall surrounding. We've got the testicle here. We have the tunica vaginalis that we can see, that bright white line. This actually happens to be some fluid around the testicle. Then the epididymis sits on top and lateral to the testicle itself. This person has most likely had a vasectomy, so their epididymis looks just a little bit different, but we can see the epididymal head sitting on top of the testicle. Then we see the body traveling down lateral along the side, and then we're kind of missing the tail at the end here. This is a close-up of the body, kind of out of the plane of the testicle. Here is another example of the epididymis. Again, we're kind of off to the side. There's a cyst in the middle of this one. But this is epididymis here, coming along the tail, going through the body here. So head of the epididymis, body here. Again, we're kind of missing that tail. And just another example of the epididymal head. This is very normal looking, sitting on top of the testicle. I'm not 100% sure why, but we're really usually just only interested in what the head looks like. This is most likely where we're going to see some pathology pop up. The other side of it, the tail, is going to be the first place that epididymitis is going to occur. So we do want to make sure that we look all the way through the epididymis, even though we don't actually take pictures of all of it. The tunica vaginalis and the tunica albuginea, again, are just something that's in our pictures. It's not necessarily that we're going to stop and take a long tunica vaginalis picture, but they are in our pictures. So the tunica albuginea is the bright white line that comes around the testicle, surrounds the testicle entirely. And then we have the tunica vaginalis, which are these layers here. And the reason that we can see the layers of the tunica vaginalis is because there's actually a little bit of fluid right here, that hydrocele. So we can see in a little bit those two layers of the tunica vaginalis. Again, here's a picture of the mediastinum testes. It's a very white, dense, fibrous band that comes through the middle of the testicle. So that is very normal to see. This is just another view on the mediastinum testes. We can see it cutting through here. And again, just another view of the mediastinum testes. Note too that we can see blood flow around these. These are just those little vessels that we would want to catch when we do Doppler. Here's an example of an epididymal appendix. So this is the head of the epididymis, and what we have hanging off the side of it then is just this little ball of tissue. And it's important that we check these out, that we document them. If the patient is having pain, there's something called epididymal appendix torsion, or appendix torsion in general. And so this little area can get twisted on itself and cut off blood flow, and it's painful. And so we just want to make sure to put some color on. You'll see a little stock of flow in there. Here is a testicular appendix. Again, wherever they extend off of is where is the name then of that appendage. So with blood flow within the testicles, of course we want to put our color on. We want to kind of evaluate, is it completely perfusing the testicle, and then we'll get some Doppler of both an artery and a vein typically. And so when we put the color on, I like to really look through the mediastinum area. There's usually some pretty beefy arteries and veins that are running through there. And then we also have the capsular artery, which runs along the periphery of the testicle. Those ones are usually pretty prominent. So I look at those first, make sure that those have blood flow and that we're good. And then I kind of start to look at the centripetal arteries. Again, those are the ones that come into the middle of the testicle. And then we have the recurrent rami, which make the little candy cane parts. When I go to Doppler then, I'll actually choose probably a recurrent rami area to Doppler. And then if I do need venous, depending on what the protocol is, if I need venous flow, I usually will come back to the mediastinum to try to get my venous flow. So here then we have a Doppler sample of both artery and vein. So we just kind of have a typical vein that kind of phasic steady flow. And then what's important for the renal or for the, not the renal artery, the testicle artery, is that we find low resistive flow through here. So we want to make sure that there's always forward flow in that testicle. We want it to be relatively well perfused. We don't want over perfusion, like really high velocities or really high EDV velocities. And we don't want any gap in here, and we definitely don't want any backwards flow or no flow. The spermatic cord is another place that I like to evaluate, just to make sure that there's nothing hiding up in the spermatic cord. So here we have probably a vein right here, but the spermatic cord is usually just kind of these linear structures that are running through here, and then the testicle sits down here. And this is where we're going to see a lot of our varicoceles pop up in this area, and we can check this area for hernias, and we can also look at this area, see if this looks twisted in the setting of torsion. So I just take a quick picture up at the spermatic cord. Here's another example of the spermatic cord. You can see that this one is moving, and what's happening in this picture is that the patient is doing a Valsalva maneuver. And if you recall, a Valsalva maneuver is the pressure that we create in our body to have a bowel movement. And so as a sonographer, you're going to have your patients do Valsalva maneuvers when you are examining the testicles, and you are going to want to explain that maneuver to them. So you'll have to come up with your own terminology for it. But what I have found best over the years, I usually kind of lead up to it as, okay, this is when you have a bowel movement, there's a name for the pressure that you create to have a bowel movement. It's called the Valsalva maneuver. And I will need you to kind of recreate that so I can see what happens in the testicles when you do that. And so I give them an opportunity to do it. If they can't do it or can't figure it out or just move my screen too much, some guys get really into it and like sit all the way up and flex their muscles, and then you just fall off of what you're looking at. Sometimes I'll tell them to make a fist with their thumb sticking out, kind of like a thumbs up sign, and put their thumb to their mouth and pretend like they're blowing up a balloon. So if you try it, blowing air against an area that can't accept air creates that pressure in the body. And so it actually works out really well for not only children, but grown adult men. Size-wise of the testicle, just keep these in the back of your mind what a normal testicle should be. After you do enough testicles, you kind of realize like, all right, my testicle typically fits underneath my 12-5 linear probe. I don't usually have to go into trapezoidal view too much, and it usually fills up the whole screen. And so when you put the probe down and you start looking at the testicle, you'll just get used to what a normal testicle looks like. But they do have normal values in length. 3 to 5 centimeters in length is normal, 2 to 3 centimeters in width or transverse, and then again 2 to 3 centimeters in height is typical. The adult epididymis usually is 3.8 centimeters in length, and that's going to be from the head to the tail. Quite often though, we only measure the head, and just off the top of my head here, I feel like they're usually about maybe 1.5 centimeters in length, maybe 1 centimeter in height, 1.5 centimeters in width. Again, you don't need to know those numbers, but do know the normal testicle measurements. Make sure you do know these. So why do we do testicular ultrasounds? I would say the most common reasons that I see are going to be pain, especially acute pain. Acute pain is worrisome for torsion, so we want to make sure we get those patients seen right away. So the first one is acute pain. The second most common thing would be dull pain. I've had this pain for a week or so, I don't know what's going on. And then I would say probably palpable mass would be the next most common, and then lastly probably swelling of the scrotum. Just off the top of my head, those are probably the top 4 reasons that we see testicular orders being put in. And that really covers kind of the basics of everything that we talked about. And then we did also talk about locating undescended testicles as well. The transducer that you're going to want to use then is your small parts transducer. So it's typically a 12 megahertz transducer. It should be linear. Just make sure you have out a curvilinear. I've had to do it a handful of times when the scrotum is basically the size of a grapefruit trying to think, the biggest I've had has probably been about, I don't even know. I can't even think of anything that is larger than a grapefruit. Not quite a bowling ball, but very large. And you'd be surprised. Again, denial's a huge thing. But people let things get kind of crazy, and then they come in, and we're going to take care of them. Patient prep for this. There's not so much prep needed for them coming in. What the prep is going to happen is when you give your detailed instructions to the patient to get them set up appropriately for the exam. Now, I'll tell you what I say in a little bit here, but there are examples in your lab videos that you will be watching. There's examples in there. I have a video where a couple sonographers talk about how they do it. And then I do encourage you to ask other sonographers, so your other instructors, ask them how they say it. And then when you get out to clinicals, listen really carefully to how the sonographers tell patients to get ready then. And then you'll have a really good repertoire of things that you want to put in your own spiel. And then you can get the patient set up however you need them to be set up. And the biggest thing though is to make sure that you are clear in your directions and don't make it too difficult for them. And so what I usually say, so I'll just tell you how I usually get everything set up. So I call the patient back, we go into the room, and I just have them sit down on a chair. I go over all their history with them. I don't have them, I want them to be focused on what I'm talking to them about. So I want to know, where's the palpable lump? How long have they been in pain? I go through all my history questions with them sitting in the chair, completely dressed. And then I tell them, well, I'm going to leave the room while you get ready. While I'm gone, this is what I need you to do. And then I'm pointing at things while I'm doing it. I hold up the sheet and I point to the bed. So I tell them that when I leave the room, they need to take their pants and underwear off. And they can leave it on the chair that they're sitting in. Then they need to lay down on the bed, on their back, open up the sheet and drape it over their whole body. And then I'll get them ready for the rest of it when I come back. So that's all I have them do. Pants off, lay down on the bed, cover yourself up with the sheet. And again, I kind of mime everything out while I do it. So then I leave the room, give them a minute to change. And then when I come back, I get them ready the rest of the way. So I hand them a towel, a bigger towel, and I ask them to cover their penis underneath the sheet. And I remind them that I'm only going to have their testicles out for the exam so I can get to the skin of the testicles. And then I ask them to hold the towel in place. So that keeps anything from moving outside of the towel. Erections are a thing that men get. It is easier for them, I think, to hide and feel better about it if they're kind of holding the towel down. So it just makes everybody feel a little bit more comfortable. And then I also make sure that I have the curtain drawn as well. If you have a door in your room that somebody could just walk in through, again, it's happened, right? So I make sure I have that curtain drawn for their privacy as well. And I tell them that. That's the whole care out loud. I'm going to pull this over for your privacy. Now they know why you're doing it. They feel better that you're recognizing their feelings and their privacy. It's just good patient care. But once I have them cover their penis with a towel, then I ask them to lift their testicles, put their thighs together, and then support their testicles with their thighs. And that's how I do it. And then I pull the sheet down and get started with scanning. I don't look at the testicles usually all that much while I'm scanning. I might, as I'm switching from side to side, just make sure that I'm getting to the other side. But really, you're just staring at your screen the whole time. They figure that out pretty quick, that you're not just staring at their private parts the whole time. And they will relax pretty quickly. So yeah, that's how I do it. It's worked for me. Recently I've come into the problem where I haven't been using enough gel, so I'm just going to throw it out there now. Use a lot of gel, a lot of warm gel. Don't shy on the gel for the testicles. And then when I'm done with the exam, I cover them back up immediately with the sheet, and I tell them again, I'm going to step out of the room while you get dressed and cleaned up. Feel free to leave everything on the bed. I'll take care of it. I'll meet you in the hallway when you're ready. And so I've had really good results with that spiel. Again, keeping it more simple is better. You'll end up with some weird positions or some completely naked men when you come back if you don't give the really clear directions. All right. So you'll have an opportunity to make up your own instructions for your patient in lab. So be thinking about what you want to say to your patient. All right. Protocols as far as palpable lumps go, as I mentioned, that's probably a really common reason that we're getting testicle ultrasounds ordered. So I make sure that I have the patient point out where they are feeling the lump. Now, palpable lumps on the testicles tend to be a little tricky because they're like, well, I can't really feel it. Or they'll be like, well, I can only feel it in one position. Or they'll say, oh, it kind of moves around. And so it does make it a little bit trickier. I don't particularly feel the palpable lump as well. And it's mostly because in my experience, the men can't really find their palpable lumps again. And so then I just kind of have them point out to me, well, where are you, what side are you feeling it on? Is it underneath? Is it on top? Is it under, above, over here? You know, I try to get a general area. Most palpable lumps are going to match up with pathology that you already saw while you were scanning, or they'll match up with the epididymis. So I have not had too much of a struggle to find or correlate where their palpable lump is to what I'm seeing on ultrasound. But whenever a patient does have a palpable lump, make sure that you're labeling that it's a palpable lump and then have them point out where they're feeling it. Some other things just to keep in mind when you are scanning, keep a relatively light touch, but you do have to maintain contact with the testicle skin. So use enough gel, use enough pressure if you need to. Have them rearrange if you need to get off to the side more. If things slip in between the legs, rearrange, because there's no point in getting a sub par exam done rather than just taking a moment to get a towel underneath there or have them readjust. Because the testicles are not moving, we can use a few more focal zones when we are imaging them. Your preset might come up with those automatically. And then make sure to have a curvilinear probe nearby just in case you need to get a little bit wider depth or wider field of view or even more depth into being able to see the testicle. Like I said, sometimes you have very giant testicles and you want to make sure that you're able to see all the contents of them. And then here's the Scrotum Protocol. It is very similar to the thyroid protocol. We basically just start in trans on the right side. We work our way down, 3 steps down, 3 steps across, and then we take measurements at mid, and then we're going to do color and Doppler as well. The big one for this one is to point out at the end there, you're going to do a bilateral testicle at the end. That's to show the radiologist the testicles in comparison to one another. Do they look the same? Is one heterogeneous and the other one is not? How do they look in comparison to each other? And then we also take a bilateral color picture at the end, again, to show what is a comparison of blood flow. A very common thing that patients will have is either torsion, where there's no blood flow to one testicle, or some sort of like epididymitis or orchitis. And that's too much, that's an infection, so we see a lot of blood flow with that. So if we can show both testicles and then show the pathology, because we have the one testicle that's normal and then we have the pathological testicle, it just helps to further prove at the end. So that's why we like that bilateral testicle picture at the end. All right, let's then switch over to some testicular pathology that we see. And so these first ones that I'm going to go through are just kind of fluid collections that we see outside of the body. And you should be able to just recognize these based on how they look by ultrasound. But this is a hydrocele. All the fluid around here. This is a very simple hydrocele. It's simple black anechoic fluid surrounding the testicle. The testicle usually kind of travels down to the posterior portion of the scrotal sac. And this is the most common cause of painless scrotal swelling. Having a hydrocele typically is not painful for the patient. In your notes, it talks about transilluminating. In the doctor's office, the doctor can put a flashlight on the posterior side of the testicle, and if light shines through, then that's actually a clinical way to diagnose a hydrocele. If this was all solid mass in here, and that's why the scrotum was a little bit larger, then that light wouldn't show through. So just kind of an interesting zombie apocalyptic tip when we don't have ultrasound machines anymore. I don't know. Hematoceles then are going to be blood surrounding the testicle. So sometimes we'll see debris within a hydrocele. It might just be like protein material within it, or it might be blood, but it's going to have those low-level mobile debris within. Pyoceles then are infections within the testicle. So we will see septations and kind of some grossness, probably some peripheral vascularity, as we can see in this picture over here, surrounding all of those septations. So this is probably an infected hydrocele. Spermatoceles are found only in the epididymal head, and that's because they are ductal. The efferent tubules become dilated, and so these are spermatoceles. They are filled with the sperm material, so protein material, and again, it's dilation of the efferent tubules as they go into the epididymal head. There's also a epididymal cyst that can occur, but spermatoceles are more likely than a cyst. Okay, so if you see an anechoic structure that kind of looks like a cyst up in the epididymal head, it's most likely a spermatocele versus a simple cyst. And then again, spermatoceles can only be in the epididymal head. So here we can see a little bit of the epididymal tissue, and then we've got a couple spermatoceles within it. This picture we saw earlier, this is actually the epididymis here with a giant spermatocele basically taking over all of where the epididymis would sit. As I mentioned, you can have epididymal cysts. So here we have fluid collections. Again, they just are cysts, right? Anywhere in the body, thin wall, anechoic through transmission. So here again, we can see the epididymal tissue, and then we have a cyst sitting within it. Again, this is a long view of the epididymis with a cyst within it. We can also have Tunica Albuginea cysts. So these are going to occur anywhere along the Tunica Albuginea, so typically along the periphery of the testicle. We'll get just a fluid-filled pocket. So here it is on ultrasound. We can see here, this is it on CT. Again, it usually resides along the periphery coming from the Tunica Albuginea. Another very common reason that we see patients are for varicoceles, and this is something that is most likely able to be diagnosed in the clinic. And they are going to come in, and what they'll talk about is feeling kind of like a bag of worms up on the side of the testicle. And these they're usually not painful, but sometimes they do cause a little bit of a dull ache for the patient. And so what these are abnormal dilation of that pampiniform plexus. And so they get a little bit bigger, they become a little bit more tortuous, and blood flow, instead of heading up into the body and back to the IVC, it just kind of falls back into the testicles, putting a lot of pressure in this area. The problem with that, though, is that then with all that extra pressure, all that extra blood sitting in here, that area starts to get very warm. And remember, the vas deferens comes up and around and through this area as well. And because of that extra warmth, varicoceles end up being the most common cause of correctable infertility on the male side. So if you have a patient that has been, whose wife has been, they've been trying to get pregnant and cannot, and all of her stuff checks out, then we might see patients in for their varicoceles to see if they have one. And again, this can be fixed. They just go in and embolize those veins, and it can usually be corrected. I just wanted to point out, we talked about the median raphe before. This is kind of a nice picture of it, how it extends from the testicles and up into the penis. Going back to varicoceles, sorry about that. Going back to varicoceles, they are most common on the left side. And do you have a guess as to why? Well, that is because, if you remember, the pampiniform plexus on the left side drains into the left renal vein. So there's just more pressure, there's more stuff to back up. Remember that this is because of valves malfunctioning and retrograde flow. So it's just a lot more common on the left side. Now we're a little bit more concerned if it happens on the right side, because then we're more concerned that there might be an abdominal mass causing the extra pressure, causing that retrograde flow. Maybe there's a kidney mass. Trying to think, hydronephrosis can cause it because the ureters run in very close proximity to the structures of the spermatic cord. So right side is very concerning that something intra-abdominal is going on. Left side, 100% normal that we see it over there. But when we see it, we still want to document it. So primary causes of varicoceles are going to be absent or incompetent valves. And again, we know that we have valves in our veins to keep the blood flowing in the right direction. They get worn out or stop working, and then the blood just kind of falls back to the original spot. So just like the legs, we can have, we call those varicose veins. These are varicose veins basically up the testicle. Secondary causes then, as mentioned before, some sort of abdominal neoplasm, cirrhosis, or hydronephrosis can cause extra abdominal pressure, causing the blood to fall back into the testicles. When we see them on ultrasound in the transverse view, they're going to look like a bunch of little dilated veins. If we put color on this, some of them would light up, some of them might not because they are thrombosed, which is not uncommon. But the big part to diagnosing a varicocele is that they measure over 2 millimeters. So again, getting back into, sorry, I jumped ahead of myself again here. Getting back into the symptoms, painless or dull ache. And then again, bag of worms, kind of feeling on that side there, and they might have some infertility. The slide here, again, is just reminding us that left side varicoceles are very common. Right side is a little bit more concerning for a renal mass. With the left side varicocele, there is something called a nutcracker syndrome. And basically what happens is that the left renal vein is kind of smushed in between the SMA and the aorta. And when that happens, that causes even more pressure on the system and causes the blood to back up. If you go to this website or to this YouTube video, it should bring you to a video of a patient having an ultrasound done showing the varicoceles under ultrasound. So here we are, we're going to evaluate the spermatic cord area. Remember, usually we see just kind of straight linear structures through there. Well, here we can see a bunch of little dilated spaces, and that's that dilation of the pampiniform plexus. So we're going to see dilation of the veins, and then we are going to measure the veins as they are filled with color, and then we're going to have the patient valsalva so we can see how these react to that extra pressure. Do they retrofill? When they retrofill, they typically get a little bit bigger. So I usually do exactly what's going on here. I take a non-valsalva picture with color, and then I save a valsalva picture with the same vessel being measured with valsalva, showing that it increased in size. If you have a vein that measures 2 millimeters without or 2 millimeters with the valsalva, then they are positive for a varicocele. Some other structures that we see pop up in the extratesticular areas are a sperm granuloma. Sperm granulomas are most commonly seen with patients who have had vasectomies, and they are just kind of a ball of sperm, basically, that kind of got caught in the epididymis. So they usually have relatively well-defined borders, and you can see them usually anywhere along the epididymis. I feel like I see them most often down in the tail. Scrotal pearls then are a thing that we see as well. We talked about the epididymal or testicular appendages. If those torse and stop and they lose blood flow, then they're going to die off. And then they just usually kind of fall off the testicle. And then as they roll around, they become calcified over the years, and then we can see them. So these scrotal pearls are what once were appendages. They become calcified. They're mobile echogenic balls within the testicle or within the scrotum. Thankfully, it doesn't happen too often, but we are used to evaluate for scrotal trauma. And scrotal trauma can be anything from getting kicked like by a horse or by a kid, or what they call a straddle injury, where a person falls down onto something with their legs on either side of it. So quite often like a bike seat or the bar on the bike. Any sort of trauma to the testicle, if there is swelling or bruising, we'll probably need to do an ultrasound on it. And what we're mostly looking for is, what does the testicle look like? Does it look normal? Does it look abnormal? And some of the things that we'll see in scrotal trauma, this poor person happens to have all of it, but we have a fracture. Those usually pop up as kind of wedge-shaped irregular areas within the testicle. So we can see that the testicle broke here. There's heterogeneous areas within the testicle that represent hematomas or bruising, basically. There's rupture of the testicular capsule, the tunicas, and so we have testicular contents coming out. So you really want to evaluate the side, the periphery of the testicle. You want to evaluate the periphery of the testicle and make sure it's smooth. Unfortunately, this patient's is not. And then lastly, we'll probably have a hematocele involved with this as well. So we'll have that dirty kind of debris-filled fluid around the testicle. And of course, the patient will have a history of some sort of trauma to the testicular area. Epididymitis and epididymal orchitis are related to one another. Epididymitis is just an infection within the epididymis, and then epididymal orchitis includes both the epididymis and the testicle. You can have just orchitis, but that's pretty rare and kind of difficult to come across, and that's because most epididymitis and epididymal orchitises are caused by some sort of UTI or STD. And so the patient gets the STD or the UTI usually somewhere within the urinary tract. And remember that the urethra is responsible for both semen and urine. So the bacteria can veer through the ejaculatory duct, and that's how it gets into the seminal tract. So it goes through the ejaculatory duct, works its way backwards through the vas deferens, and so the first thing that bacteria usually can get into then is the tail of the epididymis. And then it will work its way back up the epididymis ductus, and that's where we'll see it in the head here. So this example is epididymitis. We have color on the head, and you can compare the amount of blood flow that's in the head compared to the testicle. They should be relatively similar. This is just lighting up, so that really gives us an idea that something's going on here. So the patient probably has some pain going on and is most likely going to test positive for either an STD or a UTI, along with this epididymitis. Epididymal orchitis, then, remember, this is now connected to the testicle, so that the infection can keep moving through the efferent tubules and into the ret testes. Then it gets into the testicles, and this is the picture that we get. The whole testicle just lights up. This is massively hyperemic. Lots of blood flow going to this testicle trying to fight that infection. Then epididymitis and epididymal orchitis is the most common cause of acute pain. And I'm going to add a little more to that, acute pain in adults. Okay? Because we're going to learn then that torsion is the most common acute pain for adolescents. So epididymitis, epididymal orchitis is the most common cause for acute pain, more so in adults, where torsion is going to be the most common for adolescents. So torsion then is a surgical emergency. If somebody is suspected of torsion, they need to get an ultrasound as soon as possible. They're going to call the surgeon. If it's after hours, that surgeon's coming in to do the surgery. It's an emergency. And then they'll bring them into the OR. They need to try to untwist the testicle and see if they can't salvage it. Time is of the essence. So if the patient gets into the OR between 5 and 6 hours of the testicle originally torsing on itself, then the testicles, most testicles are usually saved. But look, after 12 hours, 20% of testicles can't be saved. So when we suspect torsion, we want to make sure that we're getting there, get the pictures that show it well, and get that patient back to the ER so they can finish up the next round of care. When a patient's coming in with possible torsion, the first picture I take is a color picture. Is there color in the testicle that they're having pain on? If there's color in there, cool. I'm just going to go through my protocol, not a big deal. I'm going to get really good pictures. If there's no color in there, then I'm going to really do everything I can to get diagnostic pictures as fast as I can and show that it's torsed. So torsion is basically the testicle spinning upon itself. It twists around that spermatic cord, and when it twists, that ends up cutting off blood flow to the testicular artery, which then cuts off blood flow to the testicle itself. More often than not, the patient is just sitting there, and all of a sudden they have this massive amount of pain. So quite often they'll say, I was just sitting on the couch, or I was sleeping and it happened. So they just have this sudden onset of pain, and it's horrible pain. The testicles themselves tend to get a little bit swollen because the blood is trapped within there. Because of the pain, the patient can have some nausea and vomiting along with it. And clinically what we'll see is that torsed testicle will actually sit a little bit higher because that spermatic cord is twisted upon itself and it doesn't have the same length as it did before. So the torsed testicle tends to sit a little bit closer into the body. I mentioned earlier about the tunica vaginalis and the bell clapper deformity. So remember that the tunica vaginalis does not cover the entire testicle. There's usually this bare area that kind of anchors the testicle into the scrotum. Well, with the bell clapper deformity, we have way more tunica vaginalis. This just makes it a little bit more slip and slidey in there, and so that testicle can go any which direction that it wants. So this is a very common cause of torsion. If a patient has a bell clapper deformity, again, they're going to do an orchioplexy where they sew the testicle to the scrotum wall. As far as what it looks like on ultrasound, then the torsed testicle is usually heterogeneous. Looks kind of junky, it'll look kind of swollen or edematous. And then when we put color on, again, this is that bilateral picture, we have no color over here. And this bilateral picture is showing to the radiologist, I have my settings appropriate for testicle blood flow. Look, the right one's good to go, nothing in the left one. Okay. So we always, always, always want to do this bilateral picture in all of our exams, but definitely do it in any of your epididymitis or torsion exams. Those appendages can torse as well. Remember, they can turn into scrotal pearls because of torsion. So sometimes we'll see this little heterogeneous area. If we put color on this, we probably wouldn't see any color flow in that area as well. This can also cause acute pain for the patient. And the sign that we see with this is called the blue dot sign. And so typically you can see that blue dot through the scrotum wall, kind of indicating that there's a torsion of an appendage. Some other normal findings that we see within the testicle is tubular ectasia of the ret testes. So remember, the ret testes sit within the mediastinum. This is collecting all the sperm from the seminiferous tubules, and then they're going to leave through the efferent tubules. So what we see, the ret testes end up starting to become kind of like little cystic holes. And that's totally normal, usually doesn't affect the function of anything, but it's just a very common finding that we see on the testicle. And then microlithiasis is another thing that we actually see quite often. And what we look for is how many little punctate calcifications are there. So these pictures here, this shows quite a few microcalcifications within the testicle. And what we consider to be normal is 5 or less in any one plane. So when I see microlithiasis or microcalcifications, I take a look through and I count them really quick. Is there more than 5? If there's not, I'll show them in my pictures, but then I'll note on there, minimal microlithiasis seen. If there's just scattered calcifications like this in the testicles, this is actually more concerning that this patient's going to develop malignancy at some point. So this patient might not have anything right now, but in the next year or two, they might have something pop up. So they need to have follow-up ultrasounds. So we just want to make sure that we document it, given that severe microlithiasis does have a higher chance of malignancy. All right, so that was a lot of extratesticular items that we can come across. I would say the most common ones are going to be microlithiasis, tubular ectasia of the ret testes I see quite often. The epididymitis is super common. And probably the Spermatocele and Hydroceles. I think those are probably the top 5 that we see most common. So let's talk a little bit more then about malignant scrotal masses. Malignant scrotal masses are pretty rare as in a whole. They account for only 1% of all cancers. So they're not super common cancers that people develop. What's kind of sad about them though is that the population that's most affected by malignant scrotal masses are going to be younger males between 15 and 35. And they're typically white males and have a history of an undescended testicle. And when we see malignant scrotal masses, they come in 2 types, germ cell tumors and non-germ cell tumors. Germ cell tumors make up most of the malignant scrotal masses. And again, we're not going to be able to diagnose these just by ultrasound, but if we see anything intratesticular, they assume it's cancer right away. They're just going to go and remove the testicle. They're not going to go and biopsy it. Anything that looks kind of junky within the testicle is concerning, and it just needs to come out. And then they'll do CTs to check for lymph nodes and if it metastasized anywhere, anything like that. But again, if we see anything in the testicle, it's assumed cancer right away and they'll remove it. The most common germ cell tumor is the seminoma. And then we also have mixed embryonal cell, yolk sac tumors, choriocarcinomas, and teratomas that can pop up as well. But pretty much if you see anything in the testicle, it's most likely a seminoma. So our job when a person is coming in to evaluate for a mass, we want to check, is it in the testicle or is it outside of the testicle? And the doctors have a pretty good idea when they send them to us in the clinic. They can feel the testicle, again, kind of like with breast. If it's mobile and feels like it's on the outside of the testicle, it's probably benign. So extratesticular masses are usually benign. But when you have intratesticular masses that are firm and fixated, those are more likely going to be cancerous. So let's start with seminoma. Again, this is the most common scrotal cancer. If you see anything hypoechoic, irregular borders, possibly some microcalcifications, if you see anything irregular within the testicle, most likely going to be a seminoma. Blood work-wise, these patients quite often have an elevated AFP or an alpha-fetoprotein. That is not good for a male who is not pregnant. Remember, the fetus's liver is usually where the AFP is developed from. So it's usually in pregnant females that we see an increase in AFP. So pregnant or males can't get pregnant. They don't have little baby livers in them. So if they have that increased AFP, we're concerned for some sort of cancer within the body. The other cancers that are germ cell in origin, I want you to know the names of them. Take a look at what they look like by ultrasound. Again, there's nothing really key about any of them. What is going to be key, though, is going to be what lab value is increased. Okay, so choriocarcinomas have an increase in beta HCG. And if you think about chorio, kind of respond or is the same as our placenta in the pregnant mom, so that makes sense that the HCG is raised. These are chorio cells, and they turn into choriocarcinoma. Embryonal cell carcinoma, then, we'll see an increase in AFP and HCG. So now think about embryos make AFP and HCG. So maybe that'll help you remember that both of these are elevated. And again, we're just seeing kind of abnormal structures within the testicles. Yolk sac tumor, again, is just AFP. But here we can see many more cystic spaces within the testicles, very abnormal appearing. And then lastly, we have teratomas. And teratomas can be found in both men and women. Remember, they're built of other human cells, so it's not uncommon to see both AFP and beta HCG rise. The thing with teratomas, though, they're not always cancerous. Just like they aren't in females, they're not always cancerous in males either. They can have hair and teeth and gross things in them. So same idea, but again, we find them within the testicle. Teratomas are probably a little bit more of the outlier, first off, because they're not always cancerous, but secondly, they're more likely to have shadowing components within them. Metastases then, pretty rare coming down to the testicles. Usually it has to come from an area that interacts with the testicles somehow. So the primary being in either the kidneys or the prostate are usually the two most common ones that come down to the testicles. And if cancer does metastasize to the testicles, it's usually going to be bilateral. Leukemia then is another blood cancer that can affect the testicles. It is more commonly going to affect the testicles in children, and it's the second most common secondary neoplasm. So as far as metastases go, leukemia is the first primary cancer, and then we get it in, it's the second most common one to send to the testicles. Lymphoma is the first. All right, so that was a lot of information about the testicles, but again, remember that's out of the male pelvis. That's kind of our bread and butter. We're going to be doing tons of those exams at least weekly. We'll be having a patient with symptoms that lead them to get a testicular ultrasound. Now we're going to switch into the ultrasound of the penis. And for both penis and prostate, we're going to go over some brief anatomy of it. I'm going to go over some brief physiology and then touch on some main pathology that we'll see with each one. do your best to understand the anatomy, what it looks like by ultrasound. I wouldn't spend massive amount of time studying either the penis or the prostate. For your boards, they're not going to ask you a ton of questions on them. You might have one or two, like what's this kind of deal. But other than that, and I think just from listening to this, none of it's going to be earth-shattering. None of it's going to be that surprising. So again, focus mostly on the scrotum for this unit. The penis and the prostate are important to recognize what they look like by ultrasound and a couple of diseases that can affect them, but they're just not going to be as prominent in a general lab. So let's start with the penis anatomy. So the penis has layers to it, and on the outside is the skin, and then we have the subcutaneous layer, and then the superficial fascia. So again, skin, superficial fascia. What's important about the superficial fascia is that it houses the superficial vein. So that's the first one here. That's the larger vein that you can see on the dorsal side of the penis. Next, then we have the areolar tissue, which is kind of a little bit more of a bulky area around. And then we have the deep fascia. And here's another term that you'll want to know. The deep fascia is the same as Buck's fascia. All right. So Buck's fascia is home then to the deep dorsal vein, and we can see that one here. And that's also surrounded by nerves and arteries. All right. So just again, we have the skin on the outside, then we have the superficial fascia that houses the superficial vein. Then we have a little bit of tissue called the areolar tissue, and then the deep fascia, which is known as Buck's fascia, home to the deep dorsal vein. Once we get into the inner layers of the penis then, the inner layers are covered by the tunica albuginea, just like the testicles are. And so it's going to cover the areas of the innards of the penis, so the corpus cavernosa, and then it's going to partially cover the corpus spongiosum. So the corpus cavernosa are two chambers that are filled with the erectile tissue on either side, and then we have the corpus spongiosum that houses the urethra here. So remember that the tunica albuginea completely surrounds the cavernosa and just part of the spongiosum. The penis has a ventral and a dorsal side. The ventral side is the underside of the penis. So I like to think about where the head of the penis comes up. There's kind of that V shape there. V for ventral, that's the underside, the part that would come in contact with the testicles as it lays flat. The dorsal side then is the side that is up and towards the abdomen. And it matters because it matters where the corpus cavernosa and the corpus spongiosum sit. So both are made of smooth muscle, and they have erectile tissue within them and also some other vascular structures that run within them. The cavernosa are going to sit more on the dorsal or the top side. So again, there's two cavernosa, one on each side, and they're more on the dorsal or top side of the penis. The spongiosum then sits more centrally on the ventral side of the penis, and that is where the urethra will travel through and out of the penis head. Here's another cross-section picture of the penis. Again, we can see here that the cavernosa are more on the dorsal side, the up side of the penis, where the spongiosum is on the ventral side. I think this looks like a little face, a little alien. But we have the cavernosa on either side, and then we have a central artery that runs through the middle of each of them. The spongiosum then is down on the bottom here, and the urethra runs through the middle of that one. So remember that the cavernosa are paired home to the deep artery or the central artery. There's only one spongiosum, and it's home to the urethra. So this picture right here is probably a good one to memorize. Vasculature to the penis is important. That's the whole reason it does what it does. And so the arterial supply to the penis comes from the pudendal arteries, which branch off of the internal iliac arteries. So remember, we have the aorta, branches into the common iliacs, which then branch into the external and internal iliacs. So the pudendal arteries come from the internal iliac arteries. And then those are going to come in to be the penis arteries. The penis arteries then are going to branch into the dorsal artery, so we can see those up here, and into the cavernosal arteries, which are the ones that run through the middle. And remember, the cavernosal arteries are also known as central arteries or as deep arteries. They have a few names. So the dorsal artery, the one that runs along the top, and the deep artery are branches of the penile arteries. Venous return then is going to come from both the dorsal and deep vein, or the superficial and deep vein. So here we can see up in the superficial fascia, we can see the superficial vein. So it gets drained from there, or from this deep dorsal vein. So as far as penis physiology, there isn't a whole lot you need to know other than that it gets erect, and when it gets erect, it ejaculates, and then the other part of it is that it urinates. So as far as erections go, knowing how it gets erect, basically what happens is blood flows in through the penile arteries and then goes into those central or deep or cavernosal arteries of the corpus cavernosum. Blood then fills the corpus cavernosum. There's kind of the spongy material in there, and it fills the cavernosa, and the veins clamp down to keep the blood in there. So erectile dysfunction usually occurs because either the blood can't get in or the blood can't stay in. So that is where the physiology of the erection is kind of important for ultrasound. So again, just mostly know that erections occur because blood fills the corpus cavernosa and then the veins clamp down to keep it in there. The other job of the penis once it's erect is then to ejaculate, and we talked about the path that the sperm and then semen takes, and then the prostate is basically this kind of ball of muscle. It helps propel the semen out of the penis. And that's it. All right, ultrasound of the penis. Let's take a look at what the normal penis looks like. So when we are scanning the penis, we'll usually have it flipped up so the ventral surface is what is being scanned. And so that's what's going on in this picture here. We're on the ventral side. So remember, the corpus sponginosum is on that ventral side, singular. And then we have the corpus cavernosa, 2 chambers on either side. This is the tunica albuginea, the kind of brighter white line. We can see that it only covers part of the cavernosum spongiosum, or corpus spongiosum, excuse me, and that it covers all of the corpus cavernosums. So this is where it's important to remember what's ventral and what's dorsal. We want to make sure that we're coming at the right angle and then able to label our parts appropriately. This is a longitudinal view then of the penis. Again, we have the dorsal side and the ventral side. This one is flipped around from the last one. We can then see here the corpus cavernosa off to one side. Reasons for doing penile ultrasound. One of them is to detect Peyronie's disease. Peyronie's disease we'll talk about in a minute here. Detection of scar tissue and plaques kind of goes along with Peyronie's disease. We might evaluate if there's a palpable lump somewhere on the penis. We can take a look at that with ultrasound. If there's been penis trauma, so concern that there might be a penile fracture, we can evaluate that with ultrasound. Or we can then also take a look at erectile dysfunction causes. Is it vascular based? So we can do Dopplers of the penile arteries and veins. Transducer that we'll want to use then is a high frequency transducer, so we can get detailed images, typically the linear one. And again, there's no patient prep for what they need to do before they come to their exam. They will need clear instructions on how to set themselves up for the actual exam itself. So just like we talked about with the scrotum, you'll want to make sure that you have a good spiel for getting them set up. Again, it's all about making your patient feel comfortable. This is they're probably in pain, they're probably worried about what's going to happen, maybe embarrassed about what's happening. So do your best just to make them feel comfortable. And then again, as I had mentioned, we usually move the penis up onto the abdomen and scan from the ventral side. Penis protocol, typically you're just going to evaluate the penis in both transverse and longitudinal planes using color, Doppler, and pulse wave Doppler to evaluate the arteries and the veins, and then imaging any palpable lumps that are indicated. All right, penile pathology then. We just have a couple that I've already mentioned that we'll just cover a little bit more in detail. So as we mentioned, the penis gets erect because blood flows in and then gets trapped in the penis. So vascular impotence can occur because either blood can't get in there because of some sort of blockage, or the veins aren't working appropriately and letting all the blood back out. So with arterial filling, we will check what the velocities are, what the waveforms look like during an erection. And during the erection part of it, the patient is injected with a medicine that gives them an erection, and then we can see how the penis reacts to it. Vascular impotence is commonly seen with people that have diabetes. Diabetes, if you recall, causes small plaques within the small vessels. And so these are very small vessels. It makes sense that they can be easily occluded by plaque. Penile trauma then usually happens during some sort of blunt force to the penis. There's usually an audible cracking sound, and what happens is a hematoma will result. And so we're just going to scan the penis looking for any abnormal appearance to it, remembering that hematomas can look different based on how old the blood is. And then lastly, Peyronie's disease. So if you remember any of these, Peyronie's disease is probably the one that you'll want to put into your memory bank, the name of it, and then know what it is. And so Peyronie's disease occurs when there are little calcifications within the penis or fibrous or scar tissue within the penis, and it causes the penis to curve. So we can see here the penis is kind of S-shaped. There's calcifications that are kind of keeping the making the penis have an abnormal shape. Here we can see it's kinked here. This one is completely curved. Erections are usually painful with these, and sometimes these calcifications can be palpable. All right, so just those three diseases that we needed to cover for the penis. Again, Peyronie's is probably the most questionable one that you would need to know. All right, so let's hop into the prostate then, get this done with. So we'll start with prostate anatomy. So the prostate is a retroperitoneal gland, and it sits kind of below and a little bit behind the bladder. So this is the bladder here, this is the prostate underneath it. It sits right behind the symphysis pubis, which is that cartilage that sits in between our hip bones. That would be right about here. And then it sits more anterior to the rectum. So we have that bone here, rectum here, bladder above it, prostate sits underneath it. It has more of a shape of an upside down pyramid. So the base is towards the bladder, where the apex then is more inferior towards the patient's feet. And then the urethra from the bladder actually runs through the middle of the prostate. So it'll run through the middle. We call that the prostatic urethra there, and then it extends out and through the penis. The normal size of the prostate is 3.8 centimeters in length, 4 centimeters in trans, and 3 centimeters in AP. The number that I would recall mostly is this 4 centimeters in trans. And I say that because when you are doing ultrasounds for kidneys and you go down to the bladder, you can actually see the prostate fairly well behind a full bladder. And sometimes you will see the prostate down there and it'll look a little large. And if you think it looks a little large, throw some calipers on it, and if it's over 4 centimeters, then I document it in both long and trans, and I just document if it looks normal or not. And then I'll put on my tech sheet, incidentally noticed enlarged prostate. So out of these numbers, I would keep in mind that 4 centimeters trans, because again, a transverse prostate is very easy to see behind a full bladder. Now, as far as memorizing anatomy goes, there are 5 zones. You have to memorize these. So take a look at these diagrams, find more diagrams on the internet, make a 3D prostate, whatever you need to do to help you memorize these. And then for each of them, or at least for a couple of them, they have something key about them that you'll also want to know. So let's start with the peripheral zone. The peripheral zone is the largest, and it's on the posterior and lateral side. So the peripheral zone is this D, and you can see that it wraps around, so it's on the lateral sides, and then it's also on the posterior side, and it's the largest area. So know that it's the largest, know where it sits, and then also know that this is the most common spot for cancers of the prostate to show up. Okay, so the next largest zone is the central zone, and this again is more towards the back or the base of the prostate, and this is the second largest zone. That's really all you need to know about that one. The third zone that you need to know is the transitional zone, and that's this area C here. This is bilateral to the urethra, so it usually kind of wraps around the urethra. And this is the most common site for BPH, or benign prostate hypertrophy. So this area is the area that's most likely to enlarge. And when it enlarges, it pushes down on the urethra, which makes it difficult for these patients to urinate fully. So that's the important part about the transitional zones. The C area wraps around the urethra, kind of saddles it. Most common site for BPH. And then remember, it's also the second most common site for malignancy. So D, or the peripheral zone, is the most common site for malignancy. The C area, the transitional zone, is the second most common site for malignancy. The periurethral glandular area, some textbooks are going to say there's only 4 zones, and it's usually because they drop this zone out. It's really just a very, very tiny, thin area that wraps around the urethra. And then lastly, we have the fibromuscular zone. That's this B area here. Again, it's just fibrous tissue and muscle to help with ejaculation, and it sits on the front or the anterior part of the gland. All right. So again, peripheral zone, largest, most common area for malignancy. Central zone is the second largest. That's all you need to know. The transitional zone saddles the urethra. Most common for BPH, second most common for malignancy. The periurethral gland, it's kind of a whatever, it's a nothing. And then the fibromuscular zone is on the anterior side. As far as blood flow getting to the prostate, there is a prostatovesical artery that comes off the internal iliac artery as well. And then once that prostatovesical artery comes off, it branches. One goes to the prostate, one goes over to the seminal vesicles in the bladder and the urethra. So know that the prostate is fed via the prostatovesical artery from the internal iliac arteries. As far as venous drainage goes, then we have the vesicoprostatic plexus. So those are veins that are draining from the prostate and the seminal vesicles, and those are going to go back to the internal iliac veins. The seminal vesicles we talked about briefly with the path of sperm and then semen. They are more closely related to the prostate, so we're going to talk about a little bit in this section of the male pelvis. So this is a picture of the prostate here, and we can see the zones drawn in here. And then right behind it, we have these like little wing things that sit off to the side, and these are seminal vesicles. So you only have one prostate, but you have 2 seminal vesicles, one on each side. And the seminal vesicles are what are going to match up with the vas deferens. They're going to receive the sperm, and they're going to add fluid to the semen, or to the sperm, to make it semen. And when the vas deferens and the seminal vesicles join, they create that ejaculatory duct. So the ejaculatory duct travels through the prostate. Prostate adds more fluid into it through the ejaculatory duct, and then they meet up at the Verumontanum. So the seminal vesicles, again, are paired. They sit on either side of the prostate and kind of inferior, posterior to the bladder. And note again that the ejaculatory ducts arise from the seminal vesicles, traveling through the central zone, and meet up to the prostatic urethra. Right, physiology then. So not much more than you need to know that the prostate is going to produce fluid that creates 30% of the volume of semen. So most of the fluid actually comes from the seminal vesicles. Prostate does a little bit of it. The prostate is also a muscle that helps with ejaculation and then stops urination. As far as labs go that you need to know for the prostate, there's only one that you need to know, and it's called the prostate-specific antigen, or PSA. And there's lots of reasons that the PSA could be elevated in a person. It could just be that their prostate's large and producing more. It could be that they have an infection in their prostate, or prostatitis. It could be that they have prostate cancer. Possibly could be that they've had a recent ejaculation, recent digital exam of their prostate, or they've had have been riding a bicycle. So there's lots of reasons why the PSA could be elevated, but the PSA is typically used as a screening tool for prostate cancer. So know that the PSA goes with prostate cancer. Then ultrasound of the prostate, like I had said before, you can see it transabdominally, see it quite often when we do kidney bladder exams. If the prostate is rather large, again, I'll just take a couple pictures of it and throw it in as an incidental finding. If it looks normal or measures under that 4 centimeters, then I don't do anything with it. But what we'll see posterior to the bladder is kind of this low level area that sits right underneath the bladder. Remember, the urethra is exiting the bladder and traveling through the prostate, so you can follow the urethra directly to the prostate. Typically, we're just going to use the curved linear probe to see this then, and then we can do transverse, long, and width measurements on it. Here again is another picture. We have the transverse prostate underneath, and then this is it in long. We can see that pubic symphysis here, that bone or cartilage, I guess. We can't really see through that with ultrasound, so it kind of blocks part of the prostate border there. And then we have the rectum behind it. So just make sure that you are measuring the prostate, not the rectum. Sometimes there can be extra stool within the rectum, and that can kind of throw things off a little bit. Transrectal, however, is the gold standard for looking at the prostate and performing prostate biopsies. So there is a probe. A lot of places actually just use the transvaginal probe. They'll use it as the transrectal probe, but there are transrectal probes that have a little bit smaller transducer head, and then they're kind of straight. Most of the transvaginal probes have a little bit of that bulbous end to it, and so either one works though. And again, transrectal is going to give us, just like it does for transvaginal, it's going to give us really detailed pictures. So now here's the prostate. Here's our prostate, and just like we are in the vagina, now we're in the rectum here. So this is the wall of the rectum. And again, we can see that we're just right up to that base of the prostate down to the apex. And then this is the preferred method again for performing biopsies. They can pick the area that they want to biopsy and get a definitive diagnosis. Some more examples of the transrectal ultrasound, TRUS. Again, the probe is inserted into the rectum. Prostate sits right next to it. This is the bladder in the far field here. So quite often you'll see that prostate exams get flipped. Here we have some calcifications in the prostate. On this picture, again, we have, this is the urethra. So we have that central zone that kind of straddles the urethra, and then we have that peripheral zone that sits along the outside of it. All right, prostate pathology. We're just about done here, guys. Prostate cancer, probably the most common prostate pathology, well, one of the more common prostate pathologies that we would see. Not something that we're definitely going to diagnose in a general lab. Prostate cancer exams are usually done by a urologist, and that's where they're going to do the transrectal ultrasound and where they'll do the biopsy as well. But prostate cancer is the most common cancer in men, and it is a variation of an adenocarcinoma. And if you remember, they usually pop up in the peripheral zone. Remember, that's the largest zone on the outside of the prostate. Some signs of prostate cancer include blood in either the urine or the semen, that elevated PSA that we talked about, and then they might have some pain in the area as well. Prostate cancer is going to have varying appearances by ultrasound. Basically, it's just going to look like a tumor within the prostate. Again, won't know what it is until it gets biopsied. Typically, they're a little bit more hypoechoic to the rest of the prostate tissue and might have some increased vascularity. Benign prostate hypertrophy is probably one of those more common incidental things that you will see, especially again while you're doing renal bladder ultrasounds. And benign prostate hypertrophy means that the prostate is enlarged. And if you remember, it was that transitional zone that typically likes to enlarge during the BPH. And as far as clinical symptoms for this, you might have heard commercials online that talk about, oh, you got to get up in the bathroom a lot to go to the bathroom. Well, that's nocturia. That means that you have to go to the bathroom a lot at night. Increased urinary frequency. The problem is that urethra is getting clamped off by the prostate. And so the patient either can't go all the way, or they feel like they've emptied, but they really didn't. So then they feel like they have to go again much sooner because they didn't actually empty. The increased pressure then of the bladder on the prostate, because that prostate's bigger, it's putting more pressure on the bladder. They feel like they have to go very urgently when they feel like it, and then they just always feel like they have a full bladder because of it. These patients can also have elevated PSA, so they might do a biopsy or they might just do an ultrasound, get measurements, see if anything's abnormal with the prostate. So here's some pictures of BPH. Again, very big, really pushes into that bottom portion of the bladder. Shouldn't invade it because it's not cancer. It's just a really, really big prostate. Prostatitis then is inflammation of the prostate. So bacterial infection gets in there. Again, we can get those from UTIs or from STDs. It all kind of follows back to that area. Main clinical symptoms are going to be having blood in your sperm or semen. If we put color on the prostate then, because it is going through an infection process, we typically see that they are hyperemic, so lots of extra blood flow. And the prostate itself might look a little enlarged and darker than we would expect. The seminal vesicles can also be seen by ultrasound. They're not something that we just typically look at. You usually won't get an ultrasound again unless you work in a urologist clinic to look at the seminal vesicles. But with seminal vesicles, there's only really one pathology that you need to know, and it's seminal vesicle cysts. And the seminal vesicle cysts are associated with what's called Zinner syndrome. And with Zinner syndrome, the patient is usually going to be missing one kidney, and the cysts show up on the side that's missing the kidney. That cyst or that seminal vesicle will usually present with cysts. And then they can have ejaculatory obstruction because of those cysts. So remember, the sperm don't turn into semen until they go by the seminal vesicles. And so if the seminal vesicles aren't working, or if they're blocked, then they're not going to have any ejaculate. As far as symptoms go, if they're not causing any sort of blockages, then they're typically asymptomatic. So you might see a tiny little cyst off to the side of the bladder, and it would be incidental at that point. If it's associated with the Zinner syndrome, then these patients have almost persistent prostatitis, which results in pain in the area, painful ejaculation, and then infertility that goes along with it. So here's our full bladder, and then we just have this kind of cluster of cysts off to the side. The prostate isn't really in this picture, but it'd be kind of in this area here. Remember, the seminal vesicles sit a little bit more superior to the prostate and off to the side of the bladder. So just some tiny little cysts in the area that we'd expect the seminal vesicles to sit. And that, my friends, is the end of the male pelvis. So just to reiterate, study your scrotum pathology, study your scrotum anatomy, really understand that. Once you understand that, read over your prostate and penis information a little bit. Again, know the prostate anatomy and know the penis anatomy. And I think you're going to be pretty well covered for your boards.